Okay, picture this. You're on call and your pager goes off. The call is from the ER. You have a patient who is completely unresponsive. What do you do? Honestly, walking into that room with an unconscious patient is one of the most intimidating moments in medicine. But here's the secret. Having a systematic approach is the key to cracking the case. So in this explainer, we're going to walk through a really high-yield guide for how to examine the unconscious patient. So here's how we're going to break it down. First, we'll define what unconsciousness even is, neurologically speaking. Then we'll look at the three main buckets of causes. From there, we'll head to the bedside and go step by step through the exam, focusing on the huge clues you can get from the eyes and from motor responses. And finally, we'll see how to put all those puzzle pieces together to figure out what's going on. First things first, before we can figure out why someone is unconscious, we have to understand what consciousness actually is and what has to break for it to go away.
So consciousness really boils down to two key components. First, you need arousal. Think of this as wakefulness, the brain's on switch. This is controlled deep in your brainstem by something called the ascending reticular activating system, or ARAS for short. But just being on isn't enough, right? You also need awareness. That's the content of your consciousness, your thoughts, your memories. And that's the job of the big boss, the cerebral cortex. A patient becomes unconscious when either their arousal system gets knocked offline, their awareness centers are massively impaired, or, of course, both.
Okay, so if unconsciousness is a failure of that arousal or awareness system, what kind of things can break it? Well, we can organize our whole list of suspects, our differential diagnoses, into three main categories. Every single time you approach an unconscious patient, your brain should immediately start sorting the possibilities into these three buckets. Is this a primary brain problem, something structurally wrong inside the skull? Is it a systemic issue, like a metabolic or toxic problem that's affecting the whole brain? Or is it an infection? Seriously, this simple framework will keep your thinking so much more organized under pressure. Let's flesh out those buckets with some of the usual suspects. For primary neurological causes, we're talking about structural problems, things like a massive stroke, a bad head trauma, a seizure, or a tumor causing increased intracranial pressure. For metabolic and toxic causes, think about the body's chemistry going haywire, dangerously low blood sugar, a lack of oxygen, or drug overdose. And finally, for infectious causes, you're thinking about things like meningitis, encephalitis, or even just overwhelming sepsis from somewhere else in the body. All right, we've got our mental framework of possibilities. Now it's time to stop theorizing and get to the bedside to start gathering clues. The real investigation begins now. Now, before you do anything else, you have to stabilize your patient. Airway, breathing, circulation. The ABCs always come first. Once you know they're stable, your assessment begins. And you start by just observing. Is there any spontaneous movement? What's their breathing pattern? After that, you need to get an objective score for their level of consciousness using a standardized tool. And that tool is the famous Glasgow Coma Scale, or GCS. It gives you a number from 3 to 15 based on their eye-opening, verbal, and motor responses. 15 is a fully alert person, just like you and me. A score of 3 represents the deepest coma or even death. It's a really crucial objective way to assess how bad things are and to communicate that clearly to the rest of the team. But the GCS is really just the start. Your focused neurological exam has three key parts: a general inspection, looking for signs of trauma or weird posturing, a deep dive into brainstem function by checking pupils and reflexes, and a careful assessment of their motor system. We're going to really zoom in on the two most revealing parts of this exam, the clues from the eyes and those motor responses. You've heard the saying, the eyes are the window to the soul, right? Well, in neurology, the eyes are the window to the brainstem. It's not an exaggeration. The pupillary light reflex pathway travels through so many different parts of the brainstem that it becomes an incredibly powerful tool for localizing exactly where the problem might be. So this is super high yield. The key is that these signs are not random. They are very specific clues. For instance, tiny little pinpoint pupils, that screams a lesion in the pons. Fixed pupils that are kind of mid-sized, that points to damage below the tectum in the midbrain. And a single blown pupil, what we call unilateral dilation, that is a full-blown neurological emergency. It often means the third cranial nerve is being compressed, maybe from the brain actually herniating. Another key brainstem test is the vestibulo-ocular reflex, which we often check with the doll's eye maneuver. In a patient with a healthy, intact brainstem, if you turn their head to one side, their eyes will move to the opposite side, like they're still trying to look straight ahead. But if the eyes just stay fixed in the middle and move with the head, that is an abnormal result and a really grave sign of severe brainstem dysfunction. Next up, we have to decode what the patient's body is trying to tell us. Even when they're unconscious, their motor responses to pain can give us huge clues. There are two classic high-yield motor patterns that you absolutely have to know. First is decorticate posturing. This is when the arms are flexed inward up on the chest while the legs are extended. This points to a lesion up high, the diencephalon. But even more ominous is decerebrate posturing. This is where all four limbs are rigidly extended. This tells you the lesion is more severe and lower down in the midbrain.
So now we've gathered all these clues. We have our GCS score, we know what the pupils are doing, and we've seen the motor posturing. The final and most satisfying step is to combine all of that into one single, coherent clinical picture.
And this is the real takeaway here. A structured exam isn't just a checklist you run through. It is a logical process of deduction. It's what allows you to go from that huge, broad list of possibilities we started with, neurologic, metabolic, infectious, and start to pinpoint a specific location of injury right inside the brain.
So let's end with a final thought to put it all together. Based on everything we've just covered, if your patient shows up with fixed, mid-dilated pupils and that classic decerebrate posturing, where is the lesion? Just think about it for a second. That is exactly how you turn signs into a diagnosis.